Okay, we might kick off. Welcome, everybody, and welcome to the 8th International Deprescribing Journal Club. Today is the Australian Deprescribing Network's turn, and we're very excited to have you all join. So my name is Nagim, and I am a lecturer and researcher at the School of Pharmacy at the University of Queensland in Brisbane. So it is morning time for us, but it might be quite different timing for a lot of you. Just a small reminder that the session today will be recorded and it will also be available on the CADeN YouTube channel for you to access after the session or to share with your friends and your peers if you'd like to do so. Our speaker today is Dr. Jean Spinks. She is a senior research fellow at the Centre for the Business and Economics of Health at the University of Queensland as well. We're very excited and lucky to have Jean come and speak to us today. So a little bit about Jean. She is trained as a health economist, a pharmacist, and a health systems researcher, and has extensive experience across these three disciplines. Her main research focuses applying economic principles to achieve better population health outcomes for medicines used in primary care. She's currently co-leading a very large funded project by MRFF called Activating Pharmacists to Reduce Medication-Related Problems, which is being undertaken with partner organizations, including big professional organizational bodies such as the Pharmaceutical Society of Australia, PHNs, Primary Healthcare Networks, NACHOs, and the Australian Digital Health Agency. Other projects include development, implementation, and evaluation of an Indigenous medication review service called Immerse, a urinary tract infection pharmacy pilot, innovative pharmacist workforce models of care, and consumer preferences for medication services. Jean has also worked in community and hospital pharmacy in Australia and internationally in the Asia-Pacific region, including in Papua New Guinea, Indonesia, and Tonga. She has postgraduate qualifications in public health and has also undertaken a 2-year Victorian public health training scheme, and her PhD is in health economics from Monash University. So welcome, Jean, and I think I'll stop sharing my screen so that you can share your slides. Thank you.
Thanks so much. I'll get this one up. Okay, so hopefully everyone can see that in presentation mode. Yep, fantastic. Okay, so today I'm just going to take quite an interactive approach with you all, given that it's a journal club. Rather than me lecturing, it'd be really nice to get some feedback and input from you today as we move forward. So when I was asked, I was given this opportunity to come and speak to you all, so which is a great opportunity. I thought about some of the things that, you know, tinker around in my head as which is based on my clinical experience as well as my research experience, and some of the challenges, I guess, that you need to overcome in this space. So I thought we would just lift the lid, because these are not the things that you put in your publications. These are not the things that you necessarily are going to give in your presentations, you know, when you're showing your work in the best possible light. But I wanted to actually share some of the challenges and as a group, you know, sort of consider some of the possible ways around these challenges moving forward. So before we start, I just wanted to acknowledge the traditional owners on the lands on which I'm coming to you from today. So I'm based in Brisbane in Australia, and I wanted to acknowledge the Aboriginal and Torres Strait Islanders, the first owners of the unceded lands known as Australia, and pay my respects to their descendants, and also to say thank you for insisting that integrated primary care should be the norm for all people. So I think in Australia, really, they provide the gold standard of what care should be. So we all know why we're here. Medication harm is a big burden worldwide, and we're continuing to struggle with this issue as the complexity of our health system evolves. And I think we're all aware of the underlying issues as to why that is. In Australia, it's like everywhere. We think that, the estimate that's thrown around is that it's costing us 1.4 billion a year in potential harms, and that 50% of this harm is preventable. So these sort of statistics are thrown around, all the time. But what do we do about it? So if this is truly preventable, what are we doing, working from the back end of what we know is happening to actually stop these things happening, these issues happening in the front end? And that was really the motivation for this trial that we're undertaking at the moment. So this is the paper for the protocol, so I can share with you all the details of the trial, even though it's not completed. The service that we've designed in Australia is called ACTMed, so activating pharmacists to reduce medication-related problems. But we've sort of rebranded it in Australia to be activating primary care, because we want to be inclusive of all the practitioners that have involvement in looking after people with medication-related problems. And so if you haven't already done so, you can have a look at this paper. It's available free online through the Medical Journal of Australia. By way of background, I think people will probably be familiar with the PINSA trial that was undertaken in the UK, and another trial in Scotland that is really more focused on looking at risky prescribing. Here we're taking a little bit more of a broader view about medication-related problems and looking at them not just as prescribing issues, but also as the underuse. So let's say, for example, people who are meeting a certain treatment guideline who are not on a medication, for example, they slip through the cracks. Sometimes our systems aren't perfect, are they? And we know that people aren't necessarily always getting prescribed the medications that are potentially warranted for them. It could be the overprescribing, of course. It could be the lack of therapeutic monitoring. It could be the lack of HbA1c measurements, all of these type of issues that we're familiar with in our everyday work. So in terms of setting up this project, we've got, as Nagam had touched on, we've got a range of partner organisations, because we also know that change in the primary care system is quite complicated, and we need a lot of buy-in from our professional organisations, from prescribers, from practice nurses, from practices themselves. And so we've got representatives from a lot of those organisations. We've also partnered with the University of Melbourne, who have specialist software that's dedicated to quality improvement within primary care. And we're starting to see medication-related problems within this quality improvement framework. And we think that this is a really nice, neat way of actually getting the team involved, even though a lot of our activities are pharmacist-led. So what does the service look like? So basically we have a person who has a regular practice, and we can, using the Melbourne Uni software, there's two parts of the software. One is an extraction software. So you're just extracting out data based at the practice. So no identified information leaves the practice, it's contained within the practice, but we can extract that data out and run treatment algorithms over it on a nightly basis. And from that, we can identify people who are potentially at risk of medication-related problems, and they pop into a populated dashboard. The pharmacist then works through this list. What we don't want is another alert for a GP, for a general practitioner or family physician, because we know that they're used to getting alert fatigue. And so we really only want them to concentrate on those true positives, if you like, those cases that have been cleaned up. We know that primary care data is not necessarily very clean, and that's one of the issues that I want to talk to you about today. So if the pharmacist sort of basically triages these cases, they then work with the prescribers, and there's a nice system, whereby you can track where a patient is in this process, and I'll show you about how that's done in a moment, so that you know where they are at any given time. And at that point, a shared decision can be made about whether that person needs to come in for a consultation, whether they can wait for their next appointment, or whether it's something that can be resolved without contacting the patient directly. And you can see here that we might have Aboriginal and Torres Strait Islander health practitioners, practice nurses, practice managers involved in that process, and having a shared understanding of what you're going to do if a patient's identified at risk. And then obviously there's a shared decision making process with the patient themselves, and it may involve, getting additional monitoring, referral on to other specialists, or even going back to the community pharmacy. So that's essentially how the service is working. So it's not dissimilar to a pincer style program, but the clinical indicators are a little bit different. So I mentioned this earlier, so we're a little bit broader in our definition of what a medication-related problem is. Now, obviously, inappropriate use and polypharmacy and deprescribing is all, you know, within your mind here. So you can see how this type of framework is adaptable to all of those situations. And so basically what we started looking at is the hospitalizations that were turning up. We've got very limited information in Australia about medication-related hospitalizations, potentially preventable ones. But there was some nice work done by Libby Roughhead and her group down in Adelaide some years back, and they've got a large data set of veterans for whom they've got a complete record. So they've got hospitalisation data and primary care data linked. And that's how a lot of this work was originally undertaken. So if you work backwards from the hospitalisation, so let's say, for example, you're trying to avoid hypo or hyperglycemia, how could that have been prevented in primary care? Okay, well, you know, really, are we doing enough monitoring? Are people getting the HbA1c tests at the right time? Are they actually going for those tests? And then working backwards again, who is the population at risk of, you know, of getting this particular clinical indicator? So we need to define that group, and I'll show you why in a moment. And here we're talking about people with type 2 diabetes and prescribed at least one medication. They're not the only group, obviously, but in this instance, we've got a very clearly defined group, a medication-related problem, and we can say what that is, and we're clearly linking it to a hospitalization that we want to avoid. And that gives us a pathway, you know, that we can then implement and evaluate the actions of pharmacists and teams. Then how do we choose which problem? My gosh, there's a lot of problems to choose from, aren't there, when you look out there. So what we actually did was take a bunch of indicators from the hospitalization end, and I think we had about 30 to begin with. And we took a data set that is a general practice data set, and we wanted to work out like how many of those are actually measurable. Like, is the data clean enough basically to be able to identify that indicator? And also then, what ones are the prescribers going to buy into? Remembering that this is a very new way in Australia for pharmacists and prescribers to work together. And we were very conscious about the change management process that was going to be behind that. So we got a nominal group technique. We used a nominal group technique to gather together a group of general practitioners and pharmacists. And we got, with the aim of basically reducing our short list of clinical indicators down to about 5 that we could implement for the trial. And so these were some of the considerations that they come up with: value and impact and consequences. So they were really thinking through, you know, from a health systems point of view, which is what we wanted, what's the biggest bang for buck? Okay, so we've got both a value proposition going on here, which is based on, you know, clinical intuition from our prescribers and our pharmacists. And these are the indicators that they came up with. There was one that was above in position number 5, which was a falls indicator. And we actually, when we went back to the data and had a look at how do we implement that, it's really tricky. So how do we, from a list of medications that are prescribed, not dispensed, okay, prescribed medications, come up with a drug burden index or some other way of having a cutoff? You know, I think clinically we're using intuition all the time and clinical judgment, and, you know, that hard and fast rule is not necessarily there. But in a clinical algorithm, like the ones that we're implementing in the software here, you need a cutoff. You need to actually have a above and below threshold. And we were finding that really difficult. The other issue was around some more pragmatic considerations. Things like getting the results of DEXA scans are in PDFs on the in the systems that we're using in Australia, and so it's actually a little bit hard harder to actually get those results down in a way that they can be evaluated in a clinical algorithm at this stage. I mean, in the future, hopefully that will change. I'll just pause there. Are there any questions about these indicators that we've come up with here? So a lot of these indicators, I guess, really when you're looking at them are under prescribing. So they're like, I think 4 of them are actually more under prescribing than over prescribing. Certainly the diabetes indicator is about a lack of therapeutic or inadequate therapeutic monitoring. Or no, actually we didn't get that one in at the moment. So is there any questions or queries about these particular indicators that are coming up here?
Yes, Jean, thank you so much. I actually had 2 questions. One is about the clinical indicators, and perhaps I missed it, but I was wondering about the process of developing them, because obviously there's groups around Australia that are developing different clinical indicators.
Yep.
So, for example, Monash is looking at clinical indicators in residential aged care. So it might be interesting to learn a little bit more about how complex I'm assuming the process is to get to this great list here. And also my second question is, when you had that fabulous figure, lots of different colors in the shared decision making, is what is your process of identifying people at risk? Because that's obviously very
underpinning everything. Yeah, absolutely. Great questions. Thank you. So in terms of the identification of the clinical indicators, as I said, we started really with a literature review of what was available, I guess, worldwide. And we started to bring that down to test in this primary care data set that we had, because I had only previously used hospital data to have a look at these clinical indicators. But obviously primary care data is coming at it from a very different point of view. So instead of knowing that someone has been at risk and that hospitalization is realized, we have to remember that people can be at risk and there's no hospitalization. But we still have to consider these people. So we've got a lot more people that are potentially at risk, but only a proportion of those are ever going to get a hospitalization. Yeah. So we're trying to predict a much larger and action a much larger group than actually the group that's turning up in hospital. So I think a lot of these decisions to get that list of about 30, 25, I think we started with from the literature, back down to about 12 before we went to the nominal group technique, was actually getting in and playing with this data set, like literally, like, can we pull this information out? So it might be that you are trying to count the number of times a medication is dispensed, or what you think would be dispensed, because don't forget, we've got prescribing. So we know that someone is prescribed, for example, you know, an antihypertensive with 5 repeats. So we're assuming they've had it for 6 months. We don't know, but we're assuming they've had it for 6 months, and that then they're coming back and they're getting another prescribing event. We know that this data is not linked between prescribers, so it may be that people are seeing multiple prescribers. So it's sometimes a little bit tricky to actually work out from the data, are they likely to be just getting, you know, another prescription from somewhere else that we're not seeing because it's not linked to this particular record. I should talk about this data set that I'm referring to. So basically this is data from, at the time, we drew from about 75 general practices. So the average size of a practice is about 6,000 people in Australia, but might be, you know, could be quite large, could be up to 50, 60,000 people at a practice. So it's quite variable. But all of that information was available to us from these 75 practices over a period of about 2 years at the time. We've now got about 4 or 5 years of data. And you can actually, you've just got files of the medications that are being prescribed. You've got a separate file for comorbidities, items, services that have been prescribed by the doctor. So you need to link that. It's quite a lot of data. They're big files. There's a lot of linking about, you know, which question you want to answer. We've also got their pathology results, which are obviously quite immense as well. So even just the pragmatics of how clean is the HbA1c results? You know, how reliable are they? Can we actually make clinical decisions about whether we're going to screen or not screen based on whether these values are going to be reliable or not? So that was sort of the process to get those 12 down to the 12 that we took to the nominal group technique. And then it was clinician judgment at that point. It really was. And I think, you know, from a system perspective, how do we get to that global shared idea of clinical indicators? I think that's a really good point. And I don't know the answer to that at this stage. I don't know that we can remove clinical expertise from that or clinical judgment from that process at this stage. But hopefully as AI evolves, and what I'd ultimately like to get to is getting that information from hospitals. Like, let's say we are starting to see an uptick in a certain type of presentation that is medication related, that we can start to feed that information back into in a faster way than what we're doing now. And inform what should we be looking for, what problems should we be looking for in primary care, informed by what's turning up in hospital, right? It could even be what's happening in primary care as AI evolves as well, right? But I think because there's a lot of judgment, we are going to have to move to a situation where there's not hard cutoffs. It may be that the AI needs to text mine for certain words or, you know, indications that are a little bit more grey than what we're doing at the moment. But I think that's probably off in the future. Now, your second question, Nagam, remind me.
It was just about how do people how do you identify people are at risk?
At risk, yeah, that's right. So
and I think
basically,
also has a question.
Yeah, no worries. So I think, you know, we're talking about defining that population, so that when I broke that clinical indicator down, so the people who are considered at risk are the people who meet the first criteria. So let's say for the diabetes example, there's a diagnosis of type 2 diabetes. Now, even that, you know, you need to be careful. It's not always clearly found in the GP software. So it might be type 2. Are we including gestational diabetes? Are we, you know, so all of those types of considerations around the diagnosis. It's not necessarily SNOMED coded. It's not clean. You know, we're using text that GPs are writing into their EMR to be able to make this decision. So, and then whether or not they've got one or more meds. So we were kind of narrowing that group down, you know, so that we wanted to take out the group that potentially were lifestyle controlled for this group, so that they wouldn't necessarily need to have 2 HbA1cs in a year. You might only be doing it yearly or, yeah, but we wanted to bring it down to that group that we consider were at higher risk. So that was the group we're considering at risk. So, you know, at any given practice, you know, you might have 1,000 of those people potentially at risk. And then the people who are being pinged, who are meeting the indication of the indicator, which is that they haven't had their HbA1c for more than 6 months, that's our proportion. So the people who are at risk, who have that indicator turned on, versus the people who don't, who have it turned off, if you like. Yeah. So that's how we're identifying them. Camille?
I'm looking at those 6 indicators that you have on the table, and they're all looking as under treatment examples. So I wondered how you reacted when you saw that the over treatment one probably didn't score high enough, and you kind of, what was the decision to, you know, in the end leave them out, all of them, and focus really here on under treatment examples? I guess you mentioned a lot of the caveats, so I can see why it was also an issue.
And I think like deprescribing in this context is really tricky, right? To actually have a list and say, so let's say even if you wanted to count polypharmacy in a GP software, right? Are you using all drug records? So are you using the coal tar cream does that count as one, you know? When that falls off the list because it's not being used anymore, is that deprescribing, right? From a clinical algorithm point of view, right? Because the number of medicines that you have on your list have decreased. Now, the complexity here is around in the GP practice software. There's two tables that are sitting in. So we're using Best Practice and Medical Director. They're the two softwares that are compatible with our service. And they have a current list that in the GP. So the GP actually says, you know, at the moment, this is our best guess, right? This is our med rec, if you like. Then there's a historical table, and that is populated by every time they print a prescription to give to the person, right? So you can imagine a situation where if someone's going in between different practices, they've got a prescription from somewhere else. If the GP hasn't asked or the person hasn't told, that medication is not recorded anywhere, or it may be only in the current table, or it may only be coming up from the prescriptions into the current table without the GP. Look, it's very complicated as to how, you know, you can't marry those up. They're not identical tables, right? For the reason of, you know, real life. Things happen. People are getting prescriptions from a hospital, for example. That's not linked up either. We're moving. So in Australia now, we do have My Health Record, which is a program that the Australian government is running, so the Australian Digital Health Agency. So we are getting dispense information almost real time of anything that's dispensed at any point under the PBS. However, that's not integrated with the GP software. So that is not talking to each other. It's going to change, right? So I think as we're moving forward, those situations can improve. Why are we not looking at the deprescribing types of situations here? I mean, certainly we, the heart failure one is not, no, but we have looked at heart failure ones in you know, where you're using an agent that may exacerbate heart failure, for example. They were just a little bit harder to code at the medication level. I think the falls one was really interesting because that's really around a deprescribing type of framework, you know. But it's one of those ones where you're really looking then for a drug burden index or some sort of threshold, right? So let's say you're taking whatever milligram of morphine equivalent, plus minus a benzodiazepine, plus minus some type of anticholinergic. What is your actual algorithm that's going to turn that indicator on or off, right? So it's those hard and fast rules that we couldn't come to an agreement within our research team, actually, within the time frame. As time was ticking along, we sort of realized that actually this is going to be really hard within the context of this trial, and said this is the first one we'll work on outside of the context of the trial, because there's just a lot more work in thinking through what those thresholds would be. The other interesting thing was the prescribers. So one of the GPs on our team was just like, what's a drug burden index? Like, what would I do with that? Like, so we were starting to realize that we were going to have to do a whole pile of education around what a drug burden index actually was before we could actually get them to engage in the algorithm, right? So that was also a pragmatic consideration, I guess. But is it worth doing? Yes, it is. Okay. So I won't go too much into the trial because I think it's all in the paper for you if you want to have a look at it. Basically, it's a step wedge cluster randomized trial. So practices are their own controls. They got a month of onboarding, of training. It's not typical for a practice or an Aboriginal community controlled health service in Australia to have a pharmacist salaried in the practice. So some of those practices were getting a pharmacist for the first time, like sort of working as an employee. So there was obviously, you know, a bit of time that was required to find out, you know, where do I put my bag and who do I talk to? So we had a month of onboarding and training of the software as well. We had a practice algorithm, clinical algorithm. So it was actually a CAD algorithm that was being used to train people so that we got clean data when the algorithms got turned on. So you can see now we're now into May and we have finished our primary outcome data collection, yay, and I just got data sent to me yesterday. So we will now start to look at that data. But what we're doing here in this section of the trial is just letting these practices finish their intervention, but also have a look at the persistence of any effect. Are the pharmacists staying on in the practices? And if a pharmacist is or isn't there, are the GPs or practice nurses actually still engaging with the algorithm? So they're being left on until the end of August. I think I've spoken a little bit about the data that's sitting in the back end. So this data repository, which is called Data for Decisions, and the Patron program of research is being run by the University of Melbourne. And it is a really, it's quite a unique data set in Australia, because there's not a lot of general practice prescribing data that's available at the moment. But the way that the data collection works is that it comes from the practice into this Granite is that extraction system that I talked about. And then goes into this Future Health Today, which is a decision support quality improvement software. So there's sort of an interaction between the two of those. And then that data actually gets sent back to a secure data enclave at the University of Melbourne. So we don't touch and feel the data. We access the data through a virtual machine, which just protects the privacy of patients. Ultimately, we're going to also get hospitalisation and death data, which is from the hospitals, and also add that into the data enclave so that we can assess cost effectiveness. So that's the decision support software. And this is kind of cool as well. So under the lid of what's happening here is that when these people, when a cohort is identified as being at risk, they come into this dashboard, as I said earlier. But then through there, we can track where they are at any time in the system. So as the pharmacist starts cleaning this data, what we didn't realize before we piloted this is the number of deferrals that were having to be made. Why? Because the data's dirty. People are not actually at risk. They are false positives, if you like. Now, if we were pinging a GP every time that was going up, they're going to turn off to that alert, right? So having that pharmacist in there and cleaning it up, I think, has been a massive part of the success of engaging practices in this process. So we can defer people from a recommendation, remembering that one person could be pinged for a number of the clinical indicators at any given time. Now, once they get triaged by that pharmacist, they can either be deferred temporarily or permanently, and then they can be marked as being to be recalled, so that it may be going to the practice manager, and there may be a practice protocol in place to give the person a call and bring them back in for a consult if any issue is found. Obviously, there's a whole, I'm not talking about it today, but there's a whole other part of consumer engagement that we've gone through about, you know, how do consumers feel about being proactively warned that they might be potentially at risk of a problem. And then we can actually mark whether the progress has been completed by a GP. So let's say that they are to be recalled and they're going to come in and speak to their prescriber. We can see that they're sitting there in that to be progressed category. And then finally, when the action is complete, you know, that they can tick that person off. So we were also sending benchmarking reports based on this information. So you can see here, this is just an example of a report that was being sent out monthly to practices within this quality improvement framework to say, okay, so these are the to review on the solid orange line here. And this is the potential, this is the proportion of people potentially at risk down on the y-axis here. So as we would expect, the to review pile is going down. So pharmacists are working diligently through the list. My God, pharmacists love a list to work through. They've been exceptionally good at working through. We were really worried that they would be overwhelmed by the amount of work when they first opened up the dashboard. But no, they just put their head down and worked out their system, and away they went. And then you can see here on the solid green line that the actions that have been completed were going up. And so, you know, it's quite heartening for a pharmacist in a practice to see that their hard work is actually resulting in them working through, you know, this list. And we're hoping that the benchmarks are actually giving them a bit of feedback. But you can also see that, and this will be part of the trial, we need to remove those people who are false positive, both from the numerator and the denominator of the primary outcome, because they were never really at risk in the first place, potentially, right? So if there's some sort of data clean, I mean, hopefully the EMRs are getting cleaned up. So that is a benefit. It's not our aim of the trial, but I guess that's happening in the background. So in terms of the primary outcome, we've talked a lot about this ratio, and basically we're trying to reduce the number of people who are identified as the indicator being on, of the proportion of all people considered at risk. And we have a range of secondary outcomes. So our primary outcome is being measured at the individual level. As a secondary outcome, we'll measure that at the practice level to see if there's important practice level differences that could be affecting that change. We're looking at the persistence of any change over time, and then obviously the hospitalization, so potentially preventable medication-related hospitalization rate before and after the intervention as well, deaths as well. And then these number of type of practitioner actions that we are tracking through the Future Health Today software. Patient experience, health practitioner satisfaction is important, as is the false positive rate, which is hopefully can be improved by mechanisms linking the digital health agency tool with general practice overall. We will undertake then an economic evaluation, an in-trial and a modelled analysis of these hospitalizations, and look at any cost savings by proactively identifying these medication-related hospitals, but obviously with the increased cost of paying pharmacists to work with the practitioners to undertake this. So we're about to start analysing our primary outcome. Our secondary outcomes will be a little bit after that. And then ultimately, we do want to compare this, what's our comparator? I guess at the moment for the trial, it's usual care, but that's including what is called home medicine's reviews here. So process of medication management that pharmacists are currently undertaking in the home. And that's another valid comparator, I guess, like when you're looking from a funding perspective, what's going to give you the best bang for buck. So that's where we're up to. I'll pause there and see if there's any questions or queries. And if not, I'll just talk 5 minutes about economic evaluation in this space. As a health economist, it's always good to actually take it that step further and look at the evaluation of these from an economic perspective. Yes, Edward.
Hello, thank you for presenting this. This is excellent. I have a few questions. So Ed Vasquez, I'm from University of Wisconsin-Madison. A lot of these conditions are not mutually exclusive. You can have diabetes, atrial fibrillation, heart failure, and hypertension. Curious just in terms of the reality for your pharmacists, how did they triage what would happen when 5 alerts happened at the same time? And did you address all of them at the same time? Was it, one happened first? And so just talk me through that. I'm curious also just when you designed this trial, I'm not sure I quite got that comparison, but if you considered actually kind of having 2 interventions, you did this against usual care. And so if there was any consideration of sometimes you'll see A versus A plus, or you'll see A versus B, you chose to do A versus control. And so just curious about considerations for that. And then my third question just has to do with the randomization that you chose to do. Was this stratified in any way? How did you randomize from a standpoint of the different units, and just talk us through that?
Absolutely. No, they're great questions. Thank you. I'll start with the randomization question because that's easy. We basically, the only stratification we used was small versus large practices. So I think we looked at the data once they were recruited, and they were larger practices than what we were expecting. So the cutoff was 6,000 patients enrolled, active patients enrolled. And so we basically then just randomized to the start time. So we had 6 tranches that were going through. And so you just got randomized to a start date. So that was the only So in terms of, sorry, what was your second question now?
My other two questions were, what happens when 5 alerts happen at the same time?
That's right, exactly. Yeah.
And my other one was just the consideration of the A versus B versus A versus A plus, just kind of just your thoughts when you were designing this in the first place.
Yeah. Look, I think how pharmacists were triaging is it's still a work in progress, I have to say. So in the back end of this trial, we had a lot of coaching. So one of it's primary health networks in Australia provide support across primary care. And we had a pharmacist/nurse, one of those rare unicorns, who's experienced in quality improvement and quality improvement coaching in teams. But because quality improvement isn't something that pharmacists are necessarily taught in Australia, she actually had a process like where we had a monthly meeting, she had one-on-one coaching, and she very much takes the approach of what works for you works, right? So she was getting the pharmacists to go back to their team and work out how she was going to triage the patients. So it's really different. And we're collecting information on that. So we've got these plan, do, study, act cycles that are happening in terms of a quality improvement cycle. And we're getting the pharmacists to document and then give us those de-identified cycles that we will work through and analyze as well. So we don't know yet exactly. We've got some anecdotal evidence from the meetings that were being held by the QI pharmacists about how they were triaging. They were really different strategies. Some would just say, like, I'm taking this one indicator because they say, you know, my practice says this is what we want to work on first. And they would work through to the end and not touch the others. Others would say, okay, I know my patients quite well. You know, for some pharmacists, they've been in the practice. So they would be looking through for the frequent flyers and going, right, I'm going to pick all those ones out first and work through them, whether or not they've got one or more indicators at any given time. So other people had the GP involved with the process, other people didn't, you know, so really heterogeneous effects, I would have to say, and something that we want to work through in the analysis a little bit more. In terms of the comparator, we had to be a little bit pragmatic. So we've gone against usual care, which at this point is including this home medicines review. So we've made no statement as to whether patients would be included or excluded had they had a home medicines review before or after. And we have let pharmacists refer on. So it may be through this triage process, and it did happen, I think, quite a lot. It'll be really interesting when we get the data and analyze it, that if people were pinging on multiple indicators, they would get a home medicines review, right? So remembering that this triage process is it's only concentrated on a very small number of problems. And we're not touching really on health literacy issues or understanding of medication or all of those other important things. We're very conscious that this is about serious medication reviews. When we're unapologetic about that at this stage, because we think that from a cost effectiveness point of view, we want to aim for those really serious ones first, right? And I see home medicines review as, I don't know, it's the right comparator for those serious ones, because you're only allowed to have one of these reviews yearly in Australia that's funded, possibly bi-yearly, depends a little bit on the prescribing. So it's actually really difficult to say that you're going to pick all these issues up, because you can have a home medicines review, get prescribed or deprescribed something a week later, and you're at risk for the rest of the year, potentially without anyone picking that up. You may or may not be lucky enough to get that picked up, right? So I think a lot of the timeliness of this intervention, whereby you're screening a large amount of people and then narrowing it down before the triage process, it really targets, it's a much more targeted approach to medication safety from the serious perspective. But as I said, these other issues could be just as important. And I think when we get to economic evaluation, what is it that matters, right? Is it just the serious problems? And I would say no. You've also got these adherence issues, health literacy issues, confusion over medicines that can cause just as much harm. Yeah, but they're not necessarily recognised. So we've got more work. We are actually also looking at the effectiveness of home medication review using this data set, using the larger data set, and using regression discontinuity design, so we can have a quasi-experimental to have a look beyond association, to have a look whether they're causally reducing both the serious medication-related problems, but potentially even adherence issues as well. Does that answer your?
Yeah, no, thanks. That was fantastic. So I appreciate you.
So in terms of economic evaluation, so just a reminder that really, you know, if we've got, in the simplest case, the A versus B comparator, we're just looking at the incremental difference in costs and outcomes rather than absolute, okay? So the four main types of economic evaluation are there. I'm not going to go into them, except to say that it's all, the differences are all about the type of outcome that we focus on. So for a cost effectiveness analysis, your unit of outcome is natural units. Cost utility, we're going to look at quality of adjusted life years or something similar. And cost benefit analysis, outcomes are measured in dollar values. Okay. So I won't go through the technical issues here, but really just to pause on what are the outcomes that matter most in medication safety. And these are the things that we were just talking about. So a lot of these things are not measured in administrative databases. We don't have quality of life measured, you know, on an ongoing basis. Health literacy, empowerment, those types of things. Adherence can be measured to a certain extent. Polypharmacy and deprescribing, potentially, with the caveat that we've got those issues that I mentioned previously. So I'd love to hear from anyone in the chat today, you know, what your feelings are around what the most important outcomes really are. Should we be taking even, like there is another, I guess, cost economic evaluation, which is cost consequences, which is looking at a number of different outcomes concurrently, which might be the more appropriate. But I have looked at, you know, undertaken economic evaluation in this space, and it's quite a difficult problem to think about, you know, what's the end game, you know, at any given point, so that we can actually narrow down what the appropriate costs are against that action. I'll just open it up. Has anyone got any thoughts around that?
I actually had a question to Jean, and I wondered as well, just reflecting on my experience with traveling to the US and working there and knowing a little bit about how different the systems in Canada can be across different states. I wondered if we can spend a little bit of time talking about the home medicine review processes in Australia, because I think we are quite unique in that space and our ability as pharmacists to engage in medicine reviews. But also I am interested in understanding a little bit more about how we can capture health literacy and how can we actually measure that in an easy way. I don't know, is there a specific instrument or something that you like to use to be able to gauge health literacy?
Yeah, we are undertaking some work in this space that using the health literacy questionnaire. So Richard Osborne is the researcher who's been developing this, and I do know that it is getting some pickup in different countries beyond Australia. The only information that I have, like at the moment, we've got a data set of about 5,000 people for which we have health literacy, and then their dispense records. So we're trying to look at the relationship now between health literacy and low value care or low value prescribing, and try to start to unpick, you know, the relationship then between health literacy and then the relationship that a person may or may not be having with their prescriber or their pharmacist, how that might influence the result of their care. But home medicines review basically is a process in Australia whereby a pharmacist is paid by the government, so needs to be referred by a general practitioner. They get paid to go into someone's home. You actually need to get an exemption if you undertake the process outside of the person's home. They go into the person's home, have a look at, you know, their bag of medicines that's in the cupboard, do a med rec, and then have a discussion around, you know, any concerns that they might have about their medication. What are they taking regularly? Review their whole medication regime. But because you're getting a lot of information from the person themselves, the consumer themselves, the pharmacist will then write their report back to the to the GP, to the prescriber, before the consumer comes back to the prescriber and has the process. So obviously that's a very labor-intensive process, but I think a very, very valuable process in terms of actually getting the consumer input and giving the consumer time to discuss some of, building a relationship. I'm sure that other countries will share, that general practice attendances are, 0 to 6 minutes normally. You're in and you're out with your family doc, and you don't get a lot of time to necessarily mull over some of the finer points or some of the anxieties that you might have around your healthcare. So this is a way for some more information to be shared. Ranesh?
Hi, Jean. I'm a deprescribing advocate. I've had experience with my mom's long-term condition. I was just curious, on one of the slides that you had all the measurements, like what should be measured as an outcome, and empowerment was one of them.
Yeah.
And when you're talking about empowerment, are you talking about patient empowerment or the clinician empowerment?
When I wrote that slide, it was around consumer empowerment. And I have to sort of say, in that context, we were doing a program with Aboriginal and Torres Strait Islander Australians. So this group haven't traditionally had a strong relationship with pharmacists. Pharmacists wear a white coat and sit, they sit high in a dispensary, and they're sort of an authority figure to many people. And so they feel inaccessible, I think, to many Aboriginal and Torres Strait Islander people. So we had noticed that they're not getting these home medication reviews, and it was a program to increase the cultural acceptability of that program, of having programs made more accessible, having Aboriginal health workers refer, changing those pathways. And as part of a trial that we did, we actually measured empowerment, but using a tool that had been developed by Aboriginal and Torres Strait Islanders as a way of measuring their empowerment to ask questions and be involved in their care. So I use that example because at the time, we didn't want to use quality of life because we didn't feel that those questions are particularly relevant to that particular patient group. So I guess I'm questioning, even as a health economist, if quality of life is the right measure, even though that's the way we're making funding decisions of these programs ultimately.
Okay, thank you.
Fantastic. Are there any other questions for Jean? Anything that's... Oh, go for it.
Sorry, and I might have to cut out a little bit here. We have a tornado warning coming. So, however, I am interested about the caregiver role. One of the areas, and so just how this team is interacting with caregivers who often have a really important role with medication management.
Yeah, it's not something that I've spoken a lot about, but we've had a consumer advisory group since the start of the project, and they've come all the way through. So we recruited for diversity. So we do have a number of caregivers on that group, and they have been advising us in really significant ways. Even that diagram that I showed you about how the program works was co-designed. So there's been a huge co-design process around this about how do people want to interact? How do they want to be called up? If there was an issue, how do they feel about that? Who's the most appropriate person to contact? But also about the information that they would like to take away from any service. So they've also co-designed the summary of the service that a pharmacist or a GP would give them back, so that they would take it to another prescriber or keep in, because when we ask them who's managing your care, because we always talk in Australia about the family doc managing care, they said we do. We manage our own care. We're the coordinator of our care, right? So you need to, this empowerment piece is really important, I think, and unresolved in my mind. I think it's really essentially. So thank you for the question. Yeah, I think it's lots of work to do in that space.
Well, thank you so much for presenting. I'm going to hop off right now, but thank you guys.
Stay safe.
I know. I'm going to go to my safe place. Thanks.
Great. I think I might just share my screens to just talk a little bit more about other announcements as well that we have coming up. So thank you very much, Jean. Once again, it was such an interesting presentation, and I hope that our attendees found something useful. And even if it is just comparing how different our practice is here and our primary care setting here is to wherever you are in the world. If you have any questions, please feel free to reach out to Jean. I'll pop her email as well in the chat box there. So feel free to reach out to her and ask her any questions about all the interesting research she's doing. So just as a heads up, the next International Deprescribing Network will be Journal Club will be on in October, on October 30th. And we have a great speaker, Dr. Katerina Tabiajango. I hope I didn't butcher that, sorry. Katerina is such a lovely person, and I had the pleasure of meeting her at BHAM in Bern last year. And it's great that she'll be speaking to this group about reducing inappropriate prescribing in older adults and lessons learned from a Swiss primary healthcare setting. So definitely be really worthwhile if you could join us. And you can check out the next Journal Club sessions that are advertised using this link and use the QR code to sign up as well. If you have any questions for myself as the chair of the Public Engagement Subcommittee for ACTMed, the Australian Deprescribing Network, feel free to reach out to me. And we also have a website where we share all our interesting research. So if you would like to collaborate or have any questions, feel free to reach out to me. And I believe we also have Dr. Turner, Justin Turner, on the call as well. So you're more than welcome to reach out to him as well. Thank you, everyone, and I hope you have a great rest of your day/night, wherever you are. Thanks.
Thank you.